Hi, everyone. My name is Mohanad Hamandi. I'm a cardiology fellow at Mayo Clinic in Rochester. I have the absolute honor to meet with Dr. Michael Reardon at ACC 25 in Chicago. Dr. Reardon is a renowned cardiac surgeon and a TAVI pioneer at Houston Methodist Hospital, and we are be talking about the EVOLUT 5-year data. Dr. Reardon, thanks for joining us.
Well, good morning. Thanks for having me here. It'll be a pleasure to speak about this.
Amazing. To start, can you please give us a summary of the initial EVOLUT trial?
Yeah, so the EVOLUT low risk trial is the third in our series of trials going from high risk to intermediate risk to low risk. And in this trial, we took patients that were at a predicted surgical mortality risk of 3% or less based on STS, frailty, and heart team assessment, and we randomized them 1-to-1 against surgery. Our initial endpoint was a Bayesian endpoint at 2 years of all-cause mortality disabling stroke, and we're going to follow these patients over 10 years. We also have secondary endpoints that have quality of life, clinical, and echocardiographic outcomes.
Excellent. And what are the main findings of the EVOLUT 5-year data?
So the primary endpoint of all-cause mortality disabling stroke, which we've reported every year now because these are low-risk patients that have a good alternative surgery, and I want to get our data out transparently every year, is now about a point and a half better than surgery. So similar to surgery. So every time point we've seen, it's been numerically better, but statistically similar to surgery. Now, it was widening out to year 4, and between year 4 and 5, the curves are coming back together a little bit. And so one of the questions was, why would these curves come together towards the end? So we took this primary endpoint of all-cause mortality disabling stroke and broke it into its two components, disabling stroke and all-cause mortality. Disabling stroke is flat. It's similar to surgery at every time point, numerically a little bit better, but statistically similar. No change between year 3 to 4 and 4 to 5. If we look at all-cause mortality, still numerically better than surgery, and statistically similar. And between year 3 and 4, it widens out in favor of EVOLUT, and then between year 4 and 5, it comes back together closer to the midline. So my question was, well, why would this happen? So we took all-cause mortality and broke it into non-cardiovascular and cardiovascular mortality. Non-cardiovascular mortality in any population of similar risk should be randomly distributed and even. And we see that in this trial up to about year 3, and then year 3 to 4, it wobbles in favor of EVOLUT. In year 4 to 5, it wobbles back to the midline. So we shouldn't worry about that. These lines will wobble over time, but they should sit on top of each other, and they will if you follow them long enough. Then we move to cardiovascular mortality. Cardiovascular mortality should have to do with how well you relieve the aortic stenosis and the overall performance of the valve. And here we see that EVOLUT remains numerically better and statistically similar to surgery across all points up to 5 years. In fact, the delta in favor of EVOLUT in our initial 2-year endpoint was 1.1, and now it's 2.1. So seeing cardiovascular mortality maintain this excellent outcome and actually widening gives me confidence that EVOLUT remains at 5 years an effective, durable treatment for surgery against surgery in a population such as the one we tested.
Excellent. The initial trial data showed that the average age of the population was like 74 years. And how do you select patients based on the trial results who are younger than that?
Well, I think it's important when people look at this trial to realize that although the mean age was 74, if I look at patients that were less than 65, 5.8 in the EVOLUT arm, 7% in the surgical arm, meaning that 93% of the patients in both arms were at least 65, matching our guidelines, which of course says if you're 65 or less, or you're going to live 20 years or more, you should still have surgery. Now, we do see a trend across the country to move towards treating many people less than 65. And I'll have to say, if you do that, you're in a data-free zone, and you really don't know what to tell the patients. So we select as a heart team based on a couple things. First of all, I want to think about how long you're going to live. If you look at the Sweetheart study, which is great because they have a database every TAVR they do and every surgery they do, and by law, all deaths are reported, so they have 100% follow-up. They took their patients and divided them into low risk, intermediate risk, and high risk, and then divide them up in 5-year increments, 60 to 64, 65 to 69. And what they found is if you were in a high, and then they looked at median survival. If you're in the higher intermediate risk group, only intermediate patients around 70 reached a median 10-year survival. Everything else was less than that. I think we have good data for 10 years of valve survival, so all these are reasonable. If you go to low risk, you have to be over 75 before you get down to no median survival over 10 years. Below that, the median survival goes above 10 years. And so those are the people we need to think about. We do a CT scan on every patient that we're going to treat for aortic valve disease, whether we're thinking TAVR or surgery. And if they're in that intermediate zone, when you're thinking which is which, if they have big sinuses and high coronaries, and I do a TAVR, I know they're likely to get another TAVR. If they have low coronaries and small sinuses, they're probably not going to get another TAVR, and so we need to think carefully about what we need to do. And of course, for surgeons, we need to think more about putting in appropriate sized valves and doing more annular enlargements. We're less than 5% in both of the low-risk trials.
Excellent. Speaking of the valve durability, now we can say with confidence that we have randomized data that the TAVI prosthesis lasts at least for 5 years. What are the biggest challenges for valve durability in TAVI?
Well, so valve durability is based on valve design and tissue science. And each valve is different. And sometimes people look at valve durability as a class effect, surgery versus TAVR. It's not. I've been involved with several surgical valves that looked great to begin with and failed. I wrote my first paper on trifecta failure in 2017. I did a lot of Toronto stentless valves. Looked great to year 7. And so surgical valves will fail at different rates. TAVR valves are going to fail at different rates. So I think the challenges for TAVR valves are, again, just like surgical valves, valve design and tissue science. We're continuing to get better tissue science and better valve design. I think one of the advantages of the EVOLUT valve is it's basically a stentless valve because the nitinol conforms to the aortic wall and it moves, so it allows the aortic valve and the mitral valve to continue to work together because they actually work in concert. Anytime you put something rigid in there, you disturb the function of the aortic valve and you disturb the function of the mitral valve. It allows earlier laminar flow. So I think, I was asked by Dr. Granada on the panel, what do we know about durability in 5 years? And I'm going to present an in-depth of this as a late breaker at AATS in May in Seattle, so please come. It's going to be a good presentation. But there's still a lot we can glean from this. The components of biologic valve dysfunction are structural, non-structural, thrombosis, and endocarditis. We know that endocarditis is low and equal in both. We know that thrombosis is low and equal in both. Non-structural is usually moderate to severe PVL or severe patient prosthetic mismatch. We know that there's only 0.4 moderate to severe PVL in EVOLUT. That's not going to count. We know they have better hemodynamics. They're not going to have more severe patient prosthetic mismatch. That gets us down to structural valve degeneration. And if we look at our reintervention, which is a fairly gross but good way of looking at that, the rates of reintervention are no different. And very importantly, the risk of reintervention was no different in these randomized patients as opposed to some of the retrospective trials we've seen.
Excellent. What do you think the future directions after the 5-year data? Are we expecting like a 7 and 10 year?
Yeah, so the trial is going to go out for 10 years. And again, normally in these trials you report them at 1, 3, 5, and 10. Because these are low-risk patients, because they have a good alternative, which is surgery, which you know a lot about, I've pushed the sponsor to report this every year. Now, we may not do a full paper every year. We may do like we did with the 4-year data and just do a research report and give the field kind of the basic of what's going on. I think for the safety of our patients and for our ability to make good decisions for our patients, frequent, transparent reporting of low-risk data is absolutely imperative.
Wow, excellent. Since this is like a fellows in training initiative, what advice do you have for fellows interested in structural interventions?
Well, structural intervention is growing in leaps and bounds, and it will continue to grow in leaps and bounds. And you're in a very good field, very exciting. I'm very sad that I'm in my 70s now and I can't do this for 20 more years because it gets more exciting each year. And it's not just the aortic valve. We're improving the mitral valve. We're improving on the tricuspid valve. Of course, we can treat pulmonary valves. A lot of those are congenital guys. But this is going to do nothing but get better and better. Now, for my surgeons, everybody thinks surgery is going to go away. I lived through the first PCIs, and they said coronary surgery was going to go away. It hasn't gone away. It's just grown more complex. In fact, if you look at the STS TVT data, although we did more than 100,000 TAVRs last year, the surgical line was decreasing to 2020, and now it's going back up. And in my institution, I went and looked at my isolated aortic valves and from 2020 till now, and they've gone up 20%. Why is that? Because we now have a good valve clinic with heart surgeons and cardiologists working together. The low risk being approved in 2019 brings more people through the valve clinic. And if you have a well-functioning valve clinic like I do and you do at the Mayo Clinic, some of these people are going to be deemed not appropriate for TAVR and better for surgery. And that means that your surgeons will do them way more. Along with the fact that all the people doing TAVRs in less than 65, you better learn how to do TAVR explant and do it well.